Welcome and thanks for joining us for today's HIS Talk webinar. It's titled The Bug Stops Here, How Our Hospital Used Its EHR and RTLS Systems to Contain a Deadly New Virus, and it's brought to you by Versus Technology. I'm Lori from HIS Talk and I'll be moderating. I have just a few housekeeping items to make you aware of before we start. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit your questions to our presenter at any time. The presenter will answer your questions during Q&A at the end. You can use the questions box or the chat function to communicate with me anytime during the presentation. Today's webinar is being recorded, so you'll receive links to the recording and a PDF version of the PowerPoint presentation in a follow-up email from me. Our presenter today is John Olmsted, the Director of Surgical and Emergency Services at the Community Hospital in Munster, Indiana. We will also hear briefly from Stephanie Birchie, who is the Director of Marketing at Versus Technology. With that, I'll turn it over to you, John.
Thanks, and thanks everybody for giving me a chance to talk about our experiences over this past year. I'll briefly go over what's happened with us. So, who am I? John Olmsted, been in leadership since late 90s. I've published a ton of articles and about all the different innovations we've come up with as a management team. And I work in Munster, Indiana, which isn't that remote. Really, it's just a suburb of Chicago. We're just 22 miles from downtown Chicago. 445-bed hospital. We do a ton of surgeries and a very busy ER. So that's who we are. And I can take us back to April 30th. So jumping in, you know, we're a great hospital, you know, doing the regular things that great hospitals do, running around, rounding on units and whatnot. The last thing I thought of is that we were going to deal with a certifiable big deal. And but that's what happened. So I get a phone call at April 30th. My boss calls me up and says immediately, it's about, I want to say 8:30 in the morning, says, John, clear your calendar and come over to administration. So right off the bat, I'm like, I'm fired. That's it. I'm out of here. I'm racking my brain because I don't think I made anybody mad, but I do work with surgeons and they, you know, bring millions of dollars to the hospital, and I don't know, you know, I'm walking over to administration and I'm thinking, what could this possibly be about? And so I walk in there and there's a ton of people in there, so I think, phew, it's not about me. And so I go in and sit down and they start talking about some flu patient. And I was mad, honestly. I just thought, it's the flu. Who cares? Put them in isolation, you know, treat them with Tamiflu and be done with it, whatever. And then they get the CDC on the phone and Centers for Disease Control. Now, at that point, I'm starting to think it's almost like being in the Twilight Zone. You're seeing all these people from around the hospital, all our senior administrators. CDC, which up to that point, I only knew how to spell CDC. I could not have told you before this MERS incident what the CDC does. I know now, and they get on the phone and they say you have a patient with Middle Eastern Respiratory Syndrome. This is a major deal, and they start talking about all the ways they're going to handle these mass disaster patients. They're even talking about asking us about our stock of body bags. So we are flipping out. It's a major deal. This was not on the agenda for the day. And I'll tell you about exactly how it happened. Ironically, we handled things very, very well, as the news press was able to report. And the funny thing is, ironically, I say, because everything that helped us handle the MERS scenario so well had really nothing to do with preparing to deal with a new deadly disease. It didn't really have anything to do with disaster planning at all. It was us trying to do a good job. So our story, I can tell you, starts back in 2009. You kind of go back to yesteryear. I started working with the ER team in 2009, and really our ER, we do a lot of great things now. Back then, not so much. It was really not a very impressive department back then. That's why they brought us in. We had sky-high turnover. paying tons of money for overtime, or patient satisfaction couldn't be worse. Well, I guess it could be. It could be 6th percentile worse, but I mean, it was terrible. Of course, we had a paper charting system, like a lot of hospitals across America back then. It just was not impressive performance all the way around. And this, this button says it here well. I'm the nurse. They used to sell these buttons. I'm here to save your butt, not kiss it. It sounds kind of funny now, but back then, that was actually an accepted mindset. There was a lot of people that had that. It was celebrated. Makes a funny button or bumper sticker, doesn't really make for high patient satisfaction or an impressive hospital. So some of the performance examples. Now this is basic performance measures that most ERs are measured on. EKGs and within 10 minutes of chest pain patients. We were probably the worst in the nation. 90% standard, we were at 30%. Treating pain within 60 minutes. To a high degree, we didn't treat pain at all. And in fact, we had run into physicians that don't work here anymore, but they thought that it was really beneath them to treat pain. So it was just unusual. Pain rating, we didn't even measure it on patients. That's a federal guideline. You don't have a choice about that. You got to measure pain. And of course, weighing patients. We gave a lot of weight-based drugs now. We didn't even, most people we didn't weigh. So really, and even though I love this hospital, but we were not a very impressive ER once upon a time. So when we start putting together the plan, as with all departments I work with, we always start from the ground up. We work with our people, make sure we have people in place, then we make sure they have equipment and materials to take care of our patients. Then we look at processes. Most administrations, when they bring you in to fix a department, they go straight to processes. You got to cut down all this overtime. You got to improve this patient satisfaction. But if you don't have the people in place to do the job, and if they don't have the equipment and tools in place to take care of their patients, you're not going to improve the processes. So that's where we started. We started from the ground up back in 2009. I got together with probably the best management team in America. I feel, of course, Rob Hoskins, our ER manager, and Val McCartney and Andy Eckerbuck, our assistant managers, and we're just a great team. And we went to work at it, starting with people. Now, this is where we get into what's the technology that really helped us over the long term. Now, when we're taking care of staff, you want a predictable workplace. So we want our policies in place. We want evaluations done on time. We want schedules put out. Fill open positions. That's the basics. We don't need to get into that. But a major thing in America now is safety in healthcare of our nurses. I just read an article that said almost 80+% of all the violence towards nurses happens between 11 p.m. at night and 7 in the morning. That's the ER. So really, when we talk about violence in the hospitals, it's really violence in the ED. So we're obviously very concerned about this. So we went out to say, what's the best system in America we can put in place to take care of our people? And this is just the neatest thing in the world. So one of the things we got are these nifty versus locator tags. Now these things are just the neatest thing in the world. It's a real-time locator system. Originally, now we've since then used it for all kinds of stuff, but the original reason we got this, and you can see this in the picture, this on there, that little red button on the left side of the versus tag, that's a panic button. And this thing works really pretty good. It interacts with our roll-in call-out system. And so let's say you're behind a closed door and someone gets pretty intimidated. And they stand up and they say, I think I'm just going to choke you. And they will walk up. You can hit that panic button. And our security folks, they have a screen. Well, they know pretty darn close exactly where you're at. And we've got an awesome security team here at Community. They'll respond immediately, and they will get there and save the day. So it's a very, very cool system. And thankfully, we don't have to use this a ton, which is what you want. You don't want to have to use it that much. But when you need it, it comes in handy. So now these versus tags are just the coolest thing because they interact with our call light system. And so they can automatically turn off call lights so you don't have to walk over to the wall and hit a button. They give you reporting so you know how long our call light's been off. It helps with all kinds of customer service things that you're trying to do when you want to improve service to your patients. So of course it protects your people, but then it's also a nice piece of equipment that you can use to do better patient care. So it's just a really nifty thing. The second thing we put in place is our hallway camera system. Now, every hospital has security cameras, so that's not that big a deal. But we have extra security cameras. We wanted every hallway covered. This is a huge safety feature. It helps with security because, again, when it comes to violence in the ER, people rarely go straight from 0 to 10. They don't go from just sitting in a chair, a mild-mannered, regular guy, to going up and punching you in the gut. What they do is they'll ramp up and become more and more intimidating. Now, what's nice about this is that we get now anything that happens in these hallways, we have it on a 4-week DVR, and so we can back it up. So if we want to prosecute a case for intimidation where someone walks up with their fist bulb up getting ready to threaten one of our staff, it's not a he said, or he said, she said. We don't know. We have it on video. So we're able to do this again because you show a force towards these people that are exhibiting anger and aggression, it shuts down very, very quickly. So it works very, very well, but not just for security. These things are great. I got to tell you, a week doesn't go by that we don't pull up video on something. Great example. A couple weeks ago, our ER manager, Rob Hoskins, gets a phone call. Patient, either a patient or a family member. Either way, they come to the ER. It was a patient, that's right, because they come to the ER wearing some sweater that their great-grandmother knitted them, and they came to the ER, took it off, and they get home, realize they don't have it, and so now they're saying, oh, you lost my family heirloom. Now, we can argue, why were you wearing a family heirloom when you come to the ER? But that's the question for another day. We're wondering what did happen with that sweater, and you're just wondering, did they even have it on? So we pull up the handy-dandy video. Bam, actually they did have the sweater, took it off. We actually we tracked it through the hallways exactly where it went. It actually did get pitched into a laundry that we do in the hospital, but if it goes off to the hospital laundry, you're never going to see that thing again. He was able to fish it out and get it back to that patient within an hour, which is a miracle. Now, again, the main thing we got these security cams is for the safety of our staff. But honestly, we use this all the time when any kind of question comes up about what happened in the department. Super, super handy. ASCOM technology. A lot of hospitals are trying to say, how can we communicate smarter? How can we communicate better? Now, we looked at a lot of different handheld communication options. And we have some, there's one company that makes one you clip on your lapel and whatnot. It's sort of like a walk-around walkie-talkie. What we really like about these ASCOM phones, we have one pictured here, is that it's a phone. So you can take private phone calls versus if you have something clipped on your side that's again, that's a walkie-talkie. Every conversation you have is a public conversation, which you really don't want that. It has texting ability. We can send text messages. The niftiest thing I love with this is you can send one text responses. So you can send, well, let's talk about our EKGs. We can send out to our staff that are covering EKGs for the day, hey, EKG needed in room 10. They send it out. If they cannot get to that, there's a one-touch response. It says accept or reject. If they hit reject, that means they're already doing one in room 25. And then we know immediately we need to get someone else if we're going to get that EKG within 10 minutes. So it's a super cool system. It's really helped us out. It's funny, when we first got these, I was skeptical, but these things are hardy as all get out. I've dropped mine like 100 times easy. The only thing I haven't done is drop it in the toilet, but the day's not over yet. The battery lasts forever. It has an awesome battery life. So they are a super cool phone. And of course, we enacted the EPIC electronic medical record system, which has really helped us a ton. It's a great system. There's a lot of electronic medical records out there, but EPIC has really, really helped us out through transparency of what is happening across the hospital and in what's happening inside our very large department. So we put all these together, and it's worked out really, really well, of course, with the benefits of our Rollins system. Now these things are great. In the old days, it was just a call light. You hit a button, and a light shines on the outside of your door. We put in Rollins systems across the hospital, and these are great because it's a smart call system. It just helps improving communication. Yeah, you just hit a button. I got a great example here depicted where you need lab, you hit that. If the bed's clean, ready to go, bam, you hit that, so it's open for your next patient. If you need housekeeping, you hit the dirty button. If there's an emergency, of course, code blue, whatnot, you can always hit that. But these things, they're a smart system, and it really does help you improve service to the patient. My favorite thing that you can program these things. Remember our handy-dandy ASCOMs here? you program this thing. Let's say it's a patient that needs pain medicine every 2 hours. So you program this thing that it sends a text message to you if it's been 2 hours and you haven't given them pain medicine as a reminder. So it really helps, really helps improve your pain control to patients, which is gigantic across America right now. It helps keep a quiet environment, and of course has very much helped our response to call light times, which is huge in patient satisfaction. So it's really, really a great system, totally programmable to the institution's needs. So it's really nifty. Long story short, we put all this together, and we did have a lot of success. Here's just some of our measures. Remember the things we talked about before. EKGs, we've got to be up there with anyone else in the nation I'd put our hospital up against. Pain within treatment, we have to be. Remember, we were 3 hours before. I was looking at a patient the other day we treated within 11 minutes. I mean, once again, you have a broken bone. This is for broken bone pain treatment. You need pain medicine as fast as you can get it, and I'd put us up against. We're easily in the top 5%, if not top 1% in the nation. Of course, the mandatory things like weighing patients and pain patients. The only thing else that we have a problem now with weighing a patient is when they're coming in from an ambulance. They're coming in hot and they come straight to the room. We're not stopping at a scale, and neither is anybody else in America. But we actually got a trick for that we're working on for this next year. So there's always room to grow for the future. But really, we've become a top-notch hospital. Patient satisfaction, we're in the high 90s as a rule. Our overtime, we've saved a ton of money in overtime for the hospital. Our staff turnover, we've got, again, one of the lowest in the state. We actually almost have a waiting list. We actually do have a waiting list of people that want to come work for us. So it's just total success, worked out really, really well. I'm going to turn things over to Stephanie just for a second to talk a little bit about the RTLS system.
Thanks, John. That's very impressive to see how community hospital utilized this combination of technologies to help achieve those improvements in the workflow, your patient satisfaction, and the staff retention. I just wanted a quick point on the RTLS technology. The foundational benefit of any good real-time locating system is its ability to provide visibility into where people and mobile equipment are simply by wearing a badge or tagging a piece of equipment. Next slide, please, John. When RTLS is integrated to other systems, as you've seen with the Rollin Nurse Call system, the ASCOM phones, and the Epic EMR, it adds more power and functionality to those systems as well. RTLS can also be leveraged into additional applications such as patient workflow, even enterprise asset tracking, hand hygiene, and as John will even discuss, infection control. So it's not simply about tracking anymore. At Versus, we kind of use this RTLS as a dynamic engine to automate processes while still keeping everyone in the know. And one last slide there, John. For us, accurate location data is key to driving all this automation. So our clients use room-level identification for such applications as that nurse call integration. If they want to go finer with their delineation at a more bed level for maybe the bed management applications, and even some of our clients, particularly in the oncology space, use chair-level location to track treatment times and our very granular staff and patient interactions. So we at Versus, we're very proud to have played a part in community hospitals' response to the MERS situation. So let's get back to John and see and hear a little bit more about how his team used the technology to respond to that unwanted contagion. John?
Well, thanks. Yeah, it's, again, we talked about our background of all the different things that we put in a place, just trying to do better patient care, which every hospital tries to do pretty much every day. That was then. So we now back to April 30th. So the CDC is on the phone, grim, doom and gloom. You guys remember, that was one of the more depressing meetings I've ever been into, because this MERS, now we can look back and say, well, what was the big deal? You guys contained it. Was it that big a deal? Yeah, it's a certifiable big deal. This stuff comes from Saudi Arabia. Turns out you get it from camels, I suppose, is where it started. But it's passed between people now, 50% death rate. back then in May. And that's when the room really got quiet. That's about as high as you're ever going to see. It's, they made improvements since then. Now it's a whopping 30%. So it's still, this is a deadly, deadly virus out of Saudi Arabia. It's kind of like SARS, Tamiflu, the treatment of choice for flu patients, influenza. It doesn't work, of course, and basically you die of acute respiratory failure. Here's the deal. So we're, this is grim. We're in that room thinking, oh my gosh, this is doom and gloom. This is not going to go well. This is what they're worried about, is the Spanish flu. Now, the bubonic plague, yes, that was terrible. Bring out the dead. We've all seen it in the movies. But that went on for centuries. Now, hugely impactful, 20% of the world's population. But again, that went on for centuries and was just kind of a going concern. The thing with the Spanish flu, 100 million dead 1 year, bam. And that is what everybody's worried about, because now that was back before we had airplanes and all the forms of travel and whatnot. And so that's what we're all worried about, is Spanish flu Junior coming along, the super flu. And could that 100 million be a billion? Could it be? I mean, people travel so much now that's not that uncommon. You see it in movies. There's all kinds of movies about this kind of stuff. That's what everybody's worried about. That's what they're worried about with the bird flu. It's what they're worried about with MERS. And frankly, that's what we're worried about with Ebola. We're worried about the super flu. So that's what's so scary. 10 a.m. leadership meeting, the CDC section chief is on the phone with us, and that's a quote, "Life as you know it is about to change." They said, you got to go out and find out everybody that was exposed, all the staff, all the patients, all the visitors, and get ready for everything to change at your hospital at 3 p.m. So we get dispatched. This is on day one. We go out and get dispatched to find out all this information. This is on May 1st. And at 3 p.m. they get us back together again. Their go team is en route. I'm envisioning like Jason Bourne and James Bond and all these people like coming over with their super jet and coming out to save the day. They're going to set up shop and prepare for hospital closure. They actually said that. They said, well, we got to plan when we're going to close your hospital. And then they correct themselves. Oh, I mean, if we're going to close it. The scariest thing I asked is my one question for the meeting. I said, I'm thinking closing our hospital. Our county cannot survive without our hospital. Are you kidding me? We're the second biggest county in the state, and everybody relies on I'm thinking of thousands of people, of course, our patients, but the employees, all the companies, surgeons. I'm flipping out. And so I said, can a hospital even survive something like this? And they go, well, some can. I'm like, oh, great, wonderful. That's all So what we had to find out quickly. How many people were in the waiting room that patient came in? Over 24. How many employees? At least, there was 50 employees directly exposed. Now we have to go and meet with these people, tell them face to face they might have the super flu. This is where it's kind of a real deal now, because so Rob and I have to go get. We have this one. We had to meet with a ton of people, but this one sticks out. Had a really great nurse, really nice young nurse, a female nurse, been married a couple years. The kind of employee you want. Very friendly, just does a great job with patients. Married a real nice guy. They've been trying to get pregnant, and they just find out the week before that she was able to successfully get pregnant. They had a big celebration, and she comes into work that day and works with the MERS patient. And now Rob and I got to go talk to her and tell her, she was exposed to this patient with 50% death rate, and that's when it gets really real. And she was a super trooper, just very brave. But she asked the questions that everybody would have asked. What's going to happen to my baby? What's going to happen to my husband? She goes, I've been home since then. Is he exposed? How about my friends? Is it safe to get in my car? Things like that. These are all questions, and we are left really wanting to tell her everything would be just fine. But, we didn't know about that. That was at 3 p.m. So going quickly through what happened with this MERS. So that was day one. Day two, since we talked to all the employees, it gets out. We talked to the exposed employees. Now it's getting out to the non-exposed employees because people talk. the CDC gets on the phone. They say, you have to release all the information to the public, and then you have to get ready for a media onslaught. So we're just like, do we really want to tell the public? But honestly, by 10 a.m., you don't have a choice. It gets out. So now the press knows. Governor holds a big briefing, a news briefing. The CDC does as well. 4:30 that afternoon, bam, the media arrives. I went across the street, met them. They're actually pretty nice guys. We hung out at Walgreens and we're chatting for a bit. Took pictures of them. It was, yeah, I mean, I had never seen anything like it. You have all these media trucks all over the place, live from Munster. Days 3 and 4, we're on the phone constantly. We're working, 19-hour days. We're doing tons of communicating with the exposed patients or exposed employees, and then of course with the public on these super long phone calls between CDC, all departments of health, tons of physicians, of course everybody else in the hospital, and we're just making plan after plan for the what ifs. I mean, we plan for about every kind of scenario that you could under that. We set the employees up, the exposed employees, on daily check-ins. There's 50 of these folks twice a day to check in, and we're basically waiting for symptoms to show up and then get them whatever treatment we can for the super flu. Ton of employees call off. Everybody's nervous. There's stories about hospital employees that had nothing to do with this patient getting turned away from restaurants and stuff. I mean, it was a very nervous public, but we just held the standard and kept communicating all the information we could. Day 5, Governor shows up. That's him next to our CEO, Don Fesco, with all of us there that's on the team. You recognize a couple of them. I'm there as shameless as I am, trying to get in a shot with the governor. That was my goal. I wanted to meet the governor for sure because we had worked so hard to control this. And there's me on the left meeting the governor. I actually asked him if he was running for president. A typical politician, he wouldn't answer. That's me photobombing one of my peers there on the right. But it was successful. They released this message. They picked the wrong hospital, wrong state, wrong country to get a foothold. We were successful. Nice story in the Washington Post. Can't do better than that, right? 6 through 10 of the encounter, we continued to monitor our employees, continued conference calls with the media updates. We had no new infections, and that's the big deal. We had no new infections, and the final result it was that all 50 employees, after the monitoring period was over 2 weeks, were fine. There was no new infections. Meanwhile, all the time, again, we're getting told it's going to be a disaster. You're going to better stock up on body bags. It's going to be terrible. Everything's going down. But it wasn't. It wasn't a disaster. We did really, really well. We held the line. Nobody flipped out. But it all came back to this. Now, what was the deal? Now, what was it? How were we able to walk through this without really, how do we control employee panic? How do we control public panic? But outside the panic, how did we stop the spread of infection? Now, how did this happen? Was it luck or was it skill? And this is what it comes down to. Now, was there a little bit of luck? Yes, there absolutely was. The patient came in on a Monday. Now, Mondays, for those of you that haven't worked in emergency departments, every emergency department across the U.S., Mondays are the worst days to come in. People save it up through the weekend, then they go see the doctor in the morning. Doctor says, oh, man, you're really sick. You better go to the ER. So Mondays are the busiest day of any ER. And for whatever reason, we were able to get this guy straight to a room. Now, part of that was because we had been working with our physicians and with our staff on throughput, and that getting people as quickly through the system to get to open rooms. And so it worked. I mean, so really good, just good, decent patient care really played a big role in saving the day there because we were able to get that patient through the waiting room. So remember, there was 24 plus people in the waiting room? Okay, none of them ever saw this patient because he came straight in. We were able to get him basically straight to a room. And we were able to answer the top 3 questions. Who was exposed between staff, other patients, and visitors? We knew. Now for us, this went on 5 days for us, really, really 10 days, the MERS incident, what I call the MERS encounter, because we encountered MERS, but it didn't overrun us. We ran into it and held it in its place. For us, it lasted 10 days. For employees, it lasted 2 weeks. But our story, as me, Rob, Val, and Annie, our story was over in 45 minutes. because we knew that day one when they dispatched us to go and find out everybody was exposed, we knew in 45 minutes everything because we checked the tracer tags. So we knew all of our employees that were exposed to that patient because we know exactly where they went due to the tracer tag technology. So we knew everybody that was in that room the patient was in. More importantly, how long they were in that room. There were security cameras, so we knew exactly how long that patient had spent in the waiting room because we saw it. He didn't spend any time. He went straight to a room, and we saw it because of our cameras. And, of course, our electronic medical record, where people that document in there, because not everybody wears tracer tags in our hospital yet. We're getting there, but not 100%. So we were still able, through the electronic medical record, to track down people that had been in the patient's room by their charting, even when they weren't wearing tracer tag, although, to be honest, we caught all of them on security camera as well. So our story, we came back in 45 minutes. We had the list complete. There was no panic. There really wasn't that problem. Now, here's the great thing with tracer tags. Here's a great study. For two reasons. One, it's, when you go on the memory system as to who was in that patient's room and how long they were in there, people forget. And this shows right here on this study where you can see some people report that they went in the room a little bit and they were in there a lot. Some people say they didn't go in the room at all and they actually were in the room. Some people say they were in the room but honestly never set foot in the room because they were in the room right next to it. Honestly, you forget, was I in room 10 or was I in room 9? You forget which bay you were in, so you're thinking, man, maybe I was in there. But more importantly, now this 7 minutes there, none of our ER staff, including our wonderful nurse, who has gone on since then and had just a beautiful baby, nobody was in that room longer than 7 minutes. What the CDC told us, now they have an unpublished little study that you can be privy to now. Their unpublished study is that they're trying to find out how long does it take to be around someone to catch the flu or MERS or SARS or what have you. And nobody really knows. Like how long, so they know that incidental passing, so if I pass you in the hallway and I have the flu, you're not going to catch the flu from passing me in the hallway. So they know that less than 1 second or 2 seconds is not enough to catch the flu from someone. You need more of an exposure. So the best information they have, the best records they have are that the least amount of time someone spent around a flu patient and caught the flu was 11 minutes. Now this is someone in direct contact, which is basically 3 feet or so. So basically 1 to 6 feet in and around that patient was they were exposed to that patient for 11 minutes and they caught the flu. Now, they're not saying that you can't catch the flu if you're there for 10 minutes or 9 minutes or 8 minutes, but that's just the most data they have. So the first question they asked are, how long were people around that patient? And we can show, because of our tracer tags, nobody was in there longer than 7 minutes. So honestly, again, never say never, but there was a very good chance that our people weren't in there long enough to catch the flu. And of course, all of our people did. Came back negative, and then people that were in there longer with that patient, by then that patient was in isolation, and that they were wearing masks and whatnot, so they had personal protective gear on. So that was a big deal. We never would have had minus the tracer tags. So here's the deal. We knew, I mean, this really says it all. Knowledge equals power, power equals control. We knew exactly who was exposed. We knew exactly how long they were exposed for. We also knew who was not exposed. Now, we got great employees here at Community, but I tell you, when the news got out that you got a 2-week stay-at-home paid vacation in case you were exposed to MERS, I want to tell you, we had a long line of people that said, I think I was exposed to MERS. Heck, I even wanted to do that. I'll be honest with you, I didn't, but we had all kinds of people that were saying they're exposed to MERS. We had all kinds of people that were saying, well, I was at Community that day. I was exposed to it. No, you were there at 2 in the afternoon. This guy came in, I think it was closer to 7 p.m. when he came in. No, you were not exposed. We knew exactly who was not exposed in terms of waiting room patients and visitors and also other employees. And the final thing is we were able to confidently communicate this to the public. And this is what we did. We got asked the same question about 100 different times. And it all came down, they slightly changed wording, but it all came down to that, how do you know that people aren't exposed? They would say, well, someone walked through that same hallway as the patient. How do you know they're not exposed? Someone was in the same stairwell. Someone was in the same elevator as that person was 8 hours ago. Maybe they're not exposed. And these are valid questions because of the super flu That's what everybody's worried about. But you know what? This isn't chickenpox. This isn't peanut butter that you put your hand in peanut butter and put your hand on the counter, and then someone else puts their hand on that peanut butter. Now they have it. Okay, MERS isn't like that. It takes significant exposure. So we were able to confidently tell people, no, we know exactly who was exposed. We know exactly how long they're exposed. We have them quarantined, and we have contained this risk. And that is what you say. Now, I know the Ebola hospital down in Texas, they had a whole list of circumstances that we didn't, so I'm not trying to compare us directly head-to-head to them. But one thing I would honestly say is they were not able to control the message. And there's a lot of reasons for that. But I would say, looking back on it, they were not able to know exactly who was exposed. They were not able to say exactly how long people were exposed. And thus, they could not control the message. And really, it got kind of out of hand. And I know there was national story. We had one national story. I was reading about a guy that he self-quarantined himself. He was worried that he was at risk of endangering his family. And while that's to be applauded, the reality was he was in the same building as the Ebola patient about 8 hours after that guy was gone. That is not an exposure. But again, since they had no control over who was exposed and how long they're exposed, there's really nothing to be done about it. So then the story takes a life of its own, and it just runs. We were able to know for certainty who was exposed. And that really was the difference. That was everything. Now, is the moral of the story, am I saying, oh, you got to invest in this technology because, what if you get MERS, or what if you get Ebola? Are you worried about that? We'll probably won't see another MERS patient anytime soon. Ebola, I'm actually a little bit more worried about that. Turns out our friends in Homeland Security have informed our disaster manager at the hospital that they are tracking 50 people in our immediate service area that have been exposed to Ebola. Haven't come down with it yet, but guess where they're coming if they do come down with it? Exactly. They're coming in here. So I'm a little more worried about Ebola, but the reality is we're probably never going to see Ebola. There might be something else coming, fill in the blank, some new disease coming down. How about this? You ever hear of this acute flaccid myelitis? Gross. You want that? What if enterovirus D68 shows up at your door? What if resistant strain TB? What if that comes over from some foreign country? Well, I would say worry a little bit about some of these diseases. Those three right there, they're in the U.S. right now. Go to the CDC website, especially this acute flaccid myelitis. It's about 100-some kids across 30 different states that have come down with this. They basically lose all control of all their muscles, become a quadriplegic. There's no cure. They don't even know how it's transmitted. They don't know anything. It's just instant quadriplegia in a young child. This is here now. This enterovirus and D68 and, of course, resistant strain TB has been here since the 80s. So you kind of do have to worry a little bit about MERS and Ebola and everything else. So I would worry about that. But really, we invested in this. We didn't invest in this technology because we were worried about Ebola or MERS. We were taking care of our people. We wanted to take care of our patients. And ultimately, we wanted to improve our processes. So that's why we got into it, and that's why we think pretty much everybody should get into it. Quick, going into the future, what are some things that are coming up for us? We're not stopping here when it comes to technology. We always want to get better. Some things are high-tech, some things are low-tech. I won't go into it in great detail. We probably won't see an Ebola patient at this hospital, but we probably will see a shooter for too long. This violence in America, you turn on the news, you see it every day between high schools and all kinds of public places, shopping malls, and of course, that latest thing happened just a little bit ago with that, with those rioters over in France. I mean, it's just terrible. But violence is just increasing. What we want, we're meeting now to bulletproof our greeters desk. This is not our hospital. The picture I have down there with a shooter coming in. That was a practice scenario that was going on in another state. But when they see a shooter come up, I want all of our doors and windows bulletproofed. I want a panic button, so a gigantic loud alarm. If it doesn't scare off the shooter, it'll at least warn everybody in the hospital the shooter's there. And the thing that I really want that came up during, we had a semi-Ebola scare where we thought we had an Ebola patient. One of those 50 people Homeland Security was tracking. Okay, one showed up for us. And so, I mean, lucky us, they came back negative. But what our greeters said, I greet people every day, and are they just going to breathe all over me with who knows what they have? And I thought that was a fair concern. I know that 11-minute rule and all that the CDC says, but, when you're that person facing that gravely ill patient, it's a little scary. We want a greeter's desk with positive air pressure that blows the air back gently, but back towards the patient, so we're infecting or breathing all over our greeter, who runs into 175 people a day, if not 200. So some of that's one of the innovations we want to help to protect our people. Hallway call lights. We think using our RTLS system and the Versus tracer tags, we're able to innovate something that doesn't exist, as far as I know, in America today, which is a hallway call light. Now, every ER in America doesn't like to use hallways, but the reality is you can't close the doors. You can't, sorry, no vacancy, go to your next hospital. You can't do that as an ER. On top of morally wrong, it's actually a federal violation. So patients keep coming in, and we got to treat them. Every ER in America eventually sticks someone in the hallway because they're getting ready to leave or getting ready to go upstairs to be admitted. Either way, they don't need a patient room. There's no call light system. So a lot of these people just won't ask for help, and they're suffering. They have to go to the bathroom, or they need some pain medicine. They just won't ask. And we do a great job here at getting with our patients, but they don't have a call light. So we think we've innovated a hallway call light that we're really excited about because it doesn't exist. Hospital-wide equipment tracking. This is available now. This is awesome. I know this sounds just dumb, but the reality is we have a hard time finding our stuff in a hospital when you're in a hospital this big. And some of this equipment is gigantically expensive, so you really can't just buy more stuff when it's just hundreds of thousands of dollars. So you got to buy enough for what you need and then share it. And shared equipment is always difficult. With these, again, RTLS systems, you're able to go directly to where the piece of equipment is located and get it back for use. So we're really excited about getting that. That's going to help our hospital immensely. You can't count the number of hours. The thing pays for itself in the amount of hours you spend looking for equipment. So we're really excited about that. One of the final thing that I'm really excited about, we really, really, really want an internal GPS system. I can't tell you how much time we spend, and all hospitals are like this. If you're any hospital of size, you just keep adding on and adding on and adding on, and it's so expensive to build hospitals that we don't build from scratch hardly ever. So we just add on a building and add on a building, and it gets really hard to find your way around. Just like you drive around in a strange city using the GPS to go straight to your friend's house or wherever you're going, we want an internal GPS system to go. This is just the greatest thing. You can download an app to your phone and use this to find your way on the inside of a very complicated building like a hospital and find out exactly where you're at. If you're in room 421, you want to go to the gift shop or the cafeteria, you can get there and get back to your loved one's room with no problem. The thing I'm really excited about this is two things. Number one, when you come to a hospital, you're not really choosing to go to a hospital. Your doctor tells you to go, your insurance tells you to go to the hospital, or you're having an emergency where you're just going to the first available hospital. So when we talk about patient loyalty, it's really hard to get a patient to be loyal to a hospital when they have all these factors telling them where to go. But every surgeon I've worked with that says, when a patient says, no, I go to hospital X, whether it's community hospital or one of the others, the surgeon goes to that hospital to treat that patient. So if a customer wants a certain hospital, the physicians will fall in line and follow the patient. It just hardly ever happens. What I want is an app. I want a community hospital app that gets downloaded to a patient's phone, and this will truly make this their hospital. Talk about brand loyalty. That's the way to get it, because once it's in their phone, what are you going to do? Put 3 or 4 or 5 different apps in your phone for different hospitals? No, you're going to use your one. And this is going to be your hospital because you'll learn your way around very quickly. You'll be more apt to walk around the hospital because you can confidently go where you want to go. It just truly links the community to us in an environment where insurance and competing factors can kind of break that loyalty. So I'm really excited about that. To be honest, I've been called by 3 different companies just last week about this. This, as of a month ago, for me, was pie in the sky. Now it's becoming a reality, and I'm hoping in the next year we can implement this. So we're really excited about continuing to adopt technology to help our people to get better tools and equipment to take care of patients, and ultimately improve our processes. And then hopefully we'll never have to deal with another doomsday scenario like we did before. But if we do, I think we're ready. I'll turn it over to you, Lori, for any questions.
Thanks, John. Like he said, now we'd like to open it up to the audience for questions. As a reminder, use the questions section on the GoToWebinar panel to submit your questions to John. The first one, John, Jen wants to know if the EMR prompted staff to ask patients MERS-related questions after that, as was the controversy with Texas Health's Ebola scare.
We have in this case. Well, our case was again a little bit different than theirs in that our person was able to bypass. They come in the waiting room, and since we did have room, we were able to take them straight to the room. Now at that point we had not implemented that role, although we did. Our medical leadership actually talked with the folks in Texas, and so we've since then put that in where we actually have links. It's another one of the great things with our electronic medical record. We have links now to go straight to the CDC's travel site that tells you about the latest illnesses. Because there's one in South America we got to worry about now. There's one in Malaysia. I mean, they're all over the place. So it's not just Ebola or MERS. There's a ton of them. And so now we have At that time we did not. And so that's why when I was talking about is this luck or skill, well, we were kind of lucky in that as Mondays go, that patient normally would be in the waiting room at least a little bit, so I would say in terms of that, we were somewhat lucky in that we were able to take them straight to the room. Although, had this happened back in 2009, we could have been the slowest ever, and that patient still would have waited in the waiting room because that was our process back then. So I do chalk that up to us working hard with our staff to facilitate throughput. But yes, that's the beauty of electronic medical records. Now you can make this a question where it's very easy to get warning signs. Now what did happen with our electronic medical record is that our infectious disease personnel very quickly were able to say, hey, here's a guy that came from Saudi Arabia, had already been treated with the traditional treatments that you would do for the flu, and if anything, he's worse now. And so reading all that history, which is readily available in electronic medical record format versus a chart where it might be kind of hidden in a back page or whatnot, they were able to find out and think, well, that's weird. I wonder if there's something in Saudi Arabia. And then they quickly found out Saudi Arabia and the MERS crisis that they have there. And so that's where they're able to put that together. So I do chalk it up to the electronic medical record, just not so directly as we have now. Now it's very easy to find someone who's been exposed to something in a foreign country.
Okay. John would like to know, what's the level of granularity of your RTLS? Is it room, bed, chair?
Yeah, it's very, again, we originally got this for our, for the panic button. And so it's pretty tight. I mean, I guess I haven't measured exact, but I think it's down to a good less than 6 feet. I mean, they know, our security knows exactly where our staff is on that. And actually, we were running into, we had to fine-tune the system before, because if it's too sensitive, if you just walk by a room, it'll turn off a call light. Well, that's not good. That it really actually defeats the purpose. So you got to work. You don't want it overly sensitive, but you don't want it so sensitive that you have to be standing right on top of someone for it to know you're there. So there's a nice middle ground. But it's within at least 6 feet, because our security, we've tested this. They know exactly where you're at if you hit that panic button.
Okay. Laura would like to know, regarding the GPS application to guide patients, is there any security concern related to potentially providing detailed floor plans to your facility?
That is so funny you say that. Oh, man. My chief of anesthesia just asked me about that. That's to be determined. You wonder how, again, this is my dream to have. We don't have this now, but I just got contacted in the last week with companies that offer this. That I Googled this and didn't find anybody that offered it, because I would have done this years ago. Especially now that we have like 4 different parking lots and all kinds of different entrances. If you're a patient coming in for surgery, it's very confusing to find your way around community hospital. So that was one of the first concerns, to say, you're giving away your floor plan, they're going to know where everything is, and what if a shooter gets that, and then they can walk around and find their way. You know, my understanding from the companies is that there are protections and that you need to get like a patient, you know, some kind of valid order or something like that. You don't want it to be a headache for patients to use, but you do want some kind of levels of security. So that's to be determined. But it's funny you said that. Now, in terms of releasing it to the company, I don't have any concerns about that. We have that now. How many vendors that we work with that pretty much know the whole layout. But I understand what you're saying in terms of security concerns about letting just every, you know, John Q. Public know every ounce of spec of the hospital. So there is a little bit of concern with that. But I think there's a pretty easy middle ground. You know, we don't have to tell them exactly where we keep the nuclear materials from nuclear radiation. Every hospital has nuclear materials left over from nuclear med. We don't have to put that on. This is for patients to find where the waiting room is and where the cafeteria is. So I think you can limit it pretty dramatically to where it's truly just customer service oriented.
Okay. Is there a link between your RTLS and your EHR, and if so, what is it?
You know, different units have it configured different ways. Not in our electronic medical record, we have not done that yet. It's still a separate system, although you can. Case in point, we just talked about this. Discharging a patient from, you know, we don't really need it, again, for equipment. When we're talking about equipment tracking, you wouldn't want to tie that to your electronic medical record. But we're talking about discharging a patient. Now there is patient throughput. That's kind of the next phase. That's kind of phase two. Phase one is I want the equipment tracked. Phase two is patient tracking. You can do that, and Epic has a really neat application with this where, you know, your patient walks to the door and it can discharge them from the system, letting everybody know, hey, that room's open for another patient, which is great. We've not done that yet because I need the equipment first, but yes, it definitely can be done. We haven't done that to the extent here at Community yet. But that's definitely on. We've had open conversations about it because that's where we want to go.
Okay, thank you. Fred would like to know how the panic button works. Is there a message sent and to whom?
It goes straight to security. There's the screen set up for that, and if that's blipping, I mean, you want to make it simple. You don't want a big, oh, well, call this, call that. What you want is there's a screen in security. We have an awesome security team. They're there 24 hours a day. If that screen goes on, they know exactly there's a patient, there's an employee there who needs immediate help. And our guys are pretty awesome. They arrive, and they're tough guys. It works. You know, a show of force, that's your best security. Anybody that tells you, oh, you don't want to show of force, it might cause people to get violent, they haven't worked in an ER because these guys show up, yeah, it takes care of it real quick. So yeah, no, it's an almost immediate response from our security folks.
That's great. Do you have trouble getting your staff to wear the badges?
You know, in the beginning, there was a little bit of it. And what you got to do is you got to assign it permanently to the staff. And then, you know, there's little things. I mean, nothing lasts forever. Sometimes they accidentally get lost to this, that, and the other. We set up a kind of a system. It's sort of like employee badges. You know, our HR department, if you lose your badge, you know, it costs you $5. And it's more of just an annoyance fee so that when people know they're going to have to pay a little bit of money, they make sure to take care of it, because otherwise they go through badges 2 times a week. So we did the same thing with the tracer tags, and honestly, it really is. It's worked out very, very well.
To locate someone down to the chair level, can you talk about how much extra hardware would need to be added?
Oh, it's just a system that they load on, you know, one of your computers. It's great. Yeah, it's not a huge deal. Now, you know, it's tracer tags, so you got to make sure you have the system set up. And I'd probably let Stephanie answer that because I'm not a tech person. I know it works. All I know is the magic people make it work. But she could probably give you a very specifics of square footage and how much you probably need for that to set up. But once you have your department wired, it works awesome.
Thanks, John. And you're right. Once you have the sensors in place in each of the locations, they're generally for a room level default span of space, about 20 feet. What we have are simple plastic covers that have an opening in the aperture, or different apertures help to focus that room down to smaller and smaller areas. So it could be one lens cover would be more like a 6-foot range, and a different lens cover would then limit it even down to a 3-foot range over those infusion chairs that we work with in oncology. So it's the same sensor is still up in the ceiling. All we're doing is adding different lens covers, which are just very economical, a few dollars a piece. So it's very simple to help to limit the range.
Thanks, Stephanie. Our last question is, for the personnel badges, how do you coordinate maintenance on the tags? Do they require battery replacement or other periodic maintenance?
Yeah, Rob does a great job with that. But some people just say, oh, because the battery should last 9 months to a year. And a lot of departments just wait for it to quit working, because if it's, when you're wearing your tracer tag, you're going to know, the RTLS tag, you're going to know if it quits working because you walk into a room and the call light doesn't turn off. So you figure it out pretty quick if the battery's dead. But I think what's worked out best, and we've tried a couple different things, it's a work in progress, but basically every 6 months it's just easier to get in front of it and just change out that battery. But just proactively do it instead of waiting for it to die. Some people, how it goes, the people that work more, because it works on, the battery lasts for a number of hits. People that work more, because we have some people that are just workhorses and work a ton, and it's whenever we have overtime, work that. So those batteries go through faster on those people. So if you do just once a year or so, it's on some of those people it's not going to last. So if you're a department that you're okay with that, just kind of waiting, for it to die and then change it, that's fine. You'll probably use less batteries. We found the proactive. We got 120 people downstairs. We can't be policing all that, so we just set it up on the maintenance schedule.
Okay, good. Well, that was our last question, so we'll conclude our webinar. I want to thank everyone for joining us today. Thank you, John, for a really interesting and informative presentation, and thanks to Versus for bringing it to us. Attendees, watch your email for links to the recording of the webinar as well as a PDF version of the PowerPoint presentation. They should be coming to you today in a follow-up email from me. We look forward to seeing you at our next HIS Talk webinar and hope you enjoy the rest of your day.